Good afternoon. My name is Francesca Whitelaw and I ask questions on behalf of the inquiry, as I think you know. Thank you for attending today to give evidence.
I'd like to repeat after me. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that the evidence I shall give
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Now, Mr. Barrett, either stand or sit as convenient, but most people are sitting.
Could you give us your full name, please?
Mark Allen Marriott.
You should have in front of you a 13-page witness statement dated the 19th of July 2018. The reference for the transcript is INQ 005000.
Yes, I have that.
And have you had an opportunity to read that witness statement?
I have.
And are you able to confirm that the contents are true to the best of your knowledge and belief?
I can.
Thank you. And so, with your permission, the whole statement will be adduced in evidence and appear on the inquiry's website.
Yes.
May I, before we start, just make a similar warning to one I gave previously for the benefit of Dawn Sturgess's family in particular. This evidence is going to be dealing with the emergency response and the treatment of Dawn. It may well be distressing for some to listen to or to read, and the opportunity to leave if anybody wants to, or to not to watch the proceedings is now.
You'll have the point. Don't feel obliged to stay unless you want to, but it'll have to be detailed. Right.
Mr. Marriott, were you in June 2018 a paramedic employed by the South West Ambulance Service?
Yes.
Is that still your job?
Yes.
We can perhaps tell from the uniform. And at the time that you made your statement, had you been employed by the South West Ambulance Service for about 10 years?
Approximately, yes, I think it was.
And prior to that, I think you had 10 years' experience working as an intensive care paramedic in the Northern Territory in Australia, is that correct?
That's correct, yeah.
And prior to that, 11 years' experience with the London Ambulance Service, is that right?
That's correct, yeah.
And in what role or roles did you work for the London Ambulance Service?
Initially, when I joined the London Ambulance Service, it was prior to there being a paramedic programme within the UK. So initially I was just employed as a qualified ambulance person until the introduction of the paramedic programme, which came about in the very early 90s. And so I was a very early uptaker of the UK paramedic programme. And I qualified with the London Ambulance Service and trained with the London Ambulance Service as a paramedic.
Thank you. I'm going to move on to your training, and if you do need to refer to your witness statement, please do. You say that around 7 years prior to the date of the statement, so about 2011, you completed a chemical, biological, radiological and nuclear training in a location. We don't need to say the name of the location, but that this consisted of casualty retrieval from hazardous areas.
That's correct, yeah. It was just for a casualty retrieval programme. It was a volunteer scheme. They asked for staff if they wanted to be involved within that retrieval programme, and I uptook it and was shown how to don protective suits and how to retrieve patients from hot zones and so forth.
Did that training include recognition of nerve agent or other hazardous chemical poisoning symptoms?
I can't fully remember because it's such a long time ago what the content of it was. So I can't remember. It was such a long time ago.
When you were working for the South West Ambulance Service prior to the time of these events, you indicated in your witness statement that you completed local-based training updates relating to changes of procedures, equipment updates, new techniques and clinical updates. How was that training delivered?
A lot of it was, in the early days, it was face-to-face, and we would go up to one of the training centres and depending on what the content was, whether it be a 2 or 3 day course, but a lot of it was face-to-face. Generally, they did send down some literature which was prior learning so that we could update ourselves prior to being there what the content of it would be. And we also have an online, what we call ESR, which is electronic staff records, where we can log on to a training account and it will show us what areas we need to keep ourselves updated on. More recently, that has been the way things have been done. So yes, that's how I update.
And do you receive email briefings as well?
Oh, sorry?
Receive email briefings as well?
Yes, we do periodically to say that there has been a clinical or procedure update, and it would ask staff to update themselves with whatever was being updated, and we do have access to an application which is on particular types of electronic devices that we can read the latest updates and keep ourselves updated with that.
Thank you, and I think we'll come back to that in a moment. But you say in your witness statement that since the Salisbury incident you received new guidance. First of all, by the Salisbury incident, presumably you mean the poisoning of the Skripals in March 2018, is that correct?
Yeah, I believe that after the Salisbury incident, that we did receive some information on station. It generally come, if I remember, it came in a paper-type format, which was...
Sorry, in what kind of format?
Sorry?
You said it came in a particular format.
A paper format.
Paper?
A printed paper format.
Thank you.
I think normally what happened is the particular officers who were on duty at that time, they would be informed that there was an update. That officer would then print out that document and would place it on the station information table. And there would generally be a document attached to it that would say, all staff please read and update yourselves. And there was quite often a little document attached to that where with the staff names members on, so they could sign to say that they'd received and updated themselves on that document.
Thank you. Can I ask you specifically in relation to this new guidance that you were talking about post-Salisbury? First of all, can you tell us what that guidance broadly was? And if you need to refer to your statement...
Yeah, I'm sorry, I can't remember what the particular document was, but I do remember after the Salisbury incident that there was an update, and what the content of it was, I cannot remember at this stage, but I think it probably would have been advising staff to perhaps...
Well, perhaps I can help you. If you've got your statement in front of you, have
Yep.
you? Do you want to just look at it on page 4? We appreciate you made this statement some time ago, so just do you want to read the first paragraph to yourself just to refresh your memory?
What page, sorry?
Page 4 of the statement. There's a page number at the top right-hand corner, and in fact probably the bottom right-hand corner as well. Just read the first paragraph to yourself.
Sorry, what paragraph?
The top paragraph. It starts, I have received new guidance.
I've received new guidance since the previous incident in Salisbury, and the effects, sign, symptoms, the effects, signs, symptoms of a novel shock exposure, and the 1, 2, 3 step approach to dealing with casualties. This is in basic terms when you are dealing with a patient that is unresponsive. Take caution in the event of 2 patients being unresponsive. Exercise extreme caution where there are 3 or more patients unresponsive, evacuate the area and seek guidelines. So that would be pretty much what I already knew anyway.
What, the 1, 2, 3 mantra? The 1, 2, 3 rule?
Yeah.
Yes, well, I think we've heard that. But you said, what you say there is that you had new guidance dealing with the 1, 2, 3 rule, but also with the effects, signs and symptoms of Novichok exposure. Now, is that... Do you remember getting that or not?
Yeah, I mean, as I say, that's what I would have known already, and I think the document probably come out to remind staff to be aware of that again.
And do you think your memory was probably better in 2018 than it is now
Yeah,
in relation to those documents?
Forgive me, Mr. Marriott. Have you just said that everything there is something that you would have known beforehand in any event?
Sorry, I didn't quite hear you. Can you say again?
Yes. Did you just tell us that the things that were in the guidance were all things that you knew already,
Yes.
including the symptoms of Novichok?
Yes.
Where had you got that from beforehand?
Well, I knew the signs and symptoms of organophosphate poisoning and Novichok poisoning, which we would have received. They may have not called it Novichok. They may have just said that there would be a chemical attack or what type of symptoms which somebody would have got had they have been poisoned by a particular substance.
So you think you knew about hazardous chemical poisoning symptoms?
Yes.
Before
Yeah.
March 18 even?
Yes, we would have known, we would have had information, we'd have had training to say, you know, what could happen or what the signs and symptoms of some of those things would be.
Right.
Well, you say perhaps, if we look at the next paragraph, there's just 2 lines in the next paragraph where you say, I'm trained that with any suspected exposure to hazardous material to seek guidance for safety purposes, it's not specific to Novichok in isolation. It's relevant to all chemicals.
Yeah, it would be relevant to all chemicals because obviously at the point when I received that training, Novichok wasn't a word that we were familiar with, but we were aware that there were particular nerve agents.
But once we get to March 2018, there's an awareness of Novichok arising out of the Skripal poisoning. So do you think when you got that guidance after Salisbury, there was specific mention of Novichok?
I don't remember I don't remember thinking that. I mean, it's always in the back of your mind, but
So you don't actually remember now whether it's specific. And do you remember now, we know the Salisbury poisonings were in March, Dawn Sturgess was poisoned at the end of June. Do you recall when in that period you received this new guidance that you mentioned in your statement?
no, I can't remember.
And do you recall if the guidance you received after March 2018 included the potential for confusion of symptoms between drug overdose and nerve agent poisoning?
No, I don't remember.
And do you remember guidance identifying how you should treat suspected nerve agent poisoning?
Yes.
Was that specific to Novichok after March 18?
Well, I would say not specifically Novichok, but any nerve agent or organophosphate poisoning. Had I have attended a patient who were presenting with those symptoms, I would probably been alerted that there would potential for a poisoning.
So when you say no, you knew how to treat it, are you referring there to the 1, 2, 3 step approach or something else?
Yes, I would do, yeah. I mean, if I was, yeah, I mean, yeah, there's always the 1, 2, 3 step approach, yes, certainly, yeah.
In your statement, and you've also mentioned it just now, you say that within the past month, so that was within a month of July 18, all South West Ambulance Service have access to an online mobile phone application, which essentially gives an aide-memoire for clinical guidelines on various topics, including CBRN. Do you know if you had that at the time of Dawn Sturgess's poisoning?
I think I probably did have it, yeah. And I also think it was available on our electronic patient care record as well. I believe it was available on there that we could pull up those guidelines.
Did you have occasion to use it when you attended Dawn Sturgess?
I used it all the time, that particular app.
No, that wasn't the question, I don't think, Mr. Marriott. I think what the lady would like to know is whether you consulted it when you went to Muggleton Road.
I don't think I did use it when I went to Muggleton Road, no.
I'm going to bring up on screen INQ 00623, please. Sorry, 30623. A document which we saw this morning. Were you watching the evidence this morning?
I was.
So you will have seen this. This is the South West Ambulance Service Medicines Protocol. Page 1, it says 5th of January 2017 is the issue date. Were you aware of this protocol prior to June 2018?
Yes.
And if we look at the clinical situation, again, we've seen that this morning, it sets out a number of symptoms there. Can you see that on the screen in front of you?
I've only got page 1 at the moment.
Yes, page 1. We'll then go over to page 2. Can you see page 2? So are those symptoms that you were aware of in June 2018?
Yes.
And if we go to page 5, please. If we could make the bottom step 1, 2, 3 bigger. Thank you.
What number's this one, Miss Whitelaw?
This is 000623.
This is still 623, is it?
Yes, it's just page 5 of that
I
document.
do beg your pardon. Okay.
And is that the step 1, 2, 3 that you were
Yes.
referring to previously?
Yeah.
Thank you. And if we could make that smaller again. And the Duodote auto-injector, were you aware of that as well in June
Yes,
2018?
something we carry on the vehicles.
Sorry? What did you say?
It's something we carry on.
You had them on the vehicles?
Yeah, we carry more than one. I think there's 4 on the ambulances we carry.
Thank you.
Thank you. We can take that down now, please. We're now going to move to what happened on the 30th of June. You deal with this in your statement from page 4. If you need to refer to it, please do. What shift were you working on Saturday the 30th of June?
I believe it was a 0600 to 1800 day shift.
And what vehicle, what type of vehicle were you scheduled to work in?
It was a Skoda Scout RRV, and I believe the number was our call sign was 303.
Thank you. So I think you said RRV is that rapid response vehicle. And was that single crewed?
It was just myself.
What is it, a car, Mr. Marriott?
Yes.
Yeah.
And in your vehicle, was there a mobile data terminal?
There was.
I think you refer to that as MDT.
Yes.
Can you just tell us what that is, please?
A mobile data terminal is where we receive all the information of the particular incident we're being deployed on. It has a screen which is situated in front of the driver on the dashboard. When a call comes in, we receive notification on our handheld radio, and it will also simultaneously alert on the screen. Do you want me to carry on?
Well, I'm going to ask you next if there was an EPCR, an electronic patient care record as well.
That's a separate device. That's
Right.
That's located in the back, in the boot space, and it's something that it was in those days called a Panasonic Toughbook, and it had a handle on it, and it was very similar to a mobile tablet, laptop, which we would carry in onto a call where we would enter all the electronic patient care records on.
Thank you. And you were on shift 6 till 6. Was the call to Muggleton Road your first call of the day?
I believe it was. It was an unusually quiet day, so I think that was my first call of the day.
Thank you. Could we go to INQ 000653, please? And do you recognise this as the call log?
I'm not familiar with call logs because I don't ever really see these, but I've only seen it very briefly in a printed format. There's lots of numbers and things on there. I'm not completely familiar how it flows.
This is back at HQ, is it, somewhere? Is that right?
Yes.
Okay.
If you could sit slightly forward, I think the microphone's having some difficulty picking you up. Thank you very much. Just a couple, we'll try to decipher, so this isn't easy to read, and for your reference, the report of Mr. Mark Faulkner does give a summary of the call log. That's INQ 005942, page 37. So you may in slower time find it easier to refer to that, but I'll try and just pick out some key timings. It looks as though at 10:14, if you look on the screen in front of you, there was a 999 call. Could you just look at the screen and just tell me if you agree with that?
I'm sure you're right, Miss Whitelaw, and I've seen the time
Oh, I'm seeing it says...
cited as 10:14 elsewhere.
Yeah, I can
where is it on this document?
Yeah, sorry, we're page 1. We're on page 4. Could we just skip back to page 1 first? My fault.
No.
So at the top, we see 10:14,
10:14, the new call.
999, and that's the date as well.
Mm-hmm.
And then if we go to 10:16, sorry, I should say page 4 to get to 10:16. And I'm looking for 10:16:04, resource allocation 303. The highlighting is very helpful for this document, thank you. Do you see that there? You mentioned your call sign was 303.
Yeah,
so does it look like...
I think I'm looking at the right place, yes, 303, ROV.
So it looks as if you're allocated there at 10:16. And then do we also see there, just below that, 43-year-old female, conscious breathing, caller statement fitting. And then page 5, please. We should see crew 1 at the top, a few lines down, Marriott Mark. That's your name. Qualifications P. Does that mean paramedic?
It would be, yeah.
Mm-hmm.
And then resource 303, time dispatch MDT 10:16:08. Just below that for the height. Thank you. And a bit further down, RRV SALN 208 10:16 now allocated.
I think that means Salisbury North. That would indicate the location where I was at the time.
Mm-hmm.
Thank you. So does this suggest that you initially received the call at about 10:16?
Yes.
In your witness statement, you said it was about 11:10, but you couldn't be sure without checking for the log. So
I do believe that I got the time wrong because I couldn't remember the time of day for whatever reason, but obviously this doesn't lie and this is the correct information, so that was a mistake by me.
No, and you do say in your witness statement you must check the call log to be sure, so
Okay.
that's fine. If we could go to page 11, please. And I think we should see 303 on scene at 10:23. It's only a few lines down. 10:23:35. We had at scene, resource now 199 metres from scene. And then time arrived at 3:03, a few lines down, 3:03, time arrived at scene, 10:23:35. So it looks as if you received the call about 10:16 and you were there by 10:23.
I think that time is what they call an auto at scene time. So when you're within a certain distance to the job, I think it does say there 1.99.0 metres, it would automatically put us at scene, even though theoretically we may be, for instance, in the car park.
Yes.
There may be several flights of stairs or
Yes, of course.
somewhere to find. So I think it generalises, it just puts us approximately in that area.
Thank you.
It rather looks, Mr. Merritt, as if this log picks up some of the transmissions from what I think you called your mobile data terminal in the car. They're linked, are they?
Yes, they are.
Right.
We've seen on the call log it said 43-year-old female, conscious, breathing, caller statement fitting. Is that the information you would have received on your MDT?
That would initially be the information would come on the screen, but that is periodically updated. So I would expect this being the type of call it was. The operator would have continued on the line with the caller, and as more information would be coming in, they would update us accordingly. So it would update as more information would come in.
And you say in your witness statement that you received the call as a Category 1 call. That was a top priority with an immediate response.
That's correct.
Which means life at risk without an immediate response, does it?
Yeah, it was immediate response.
Do you remember if you received any other information before you attended the call?
Possibly I may have received some verbal communication. I do believe possibly I may have been told that it was a new build and that the location wasn't completely verified.
In your witness statement, you said you received a call on the radio from your ambulance control.
Yes.
Where you were advised the call is believed to be a query cardiac arrest.
Yes, I may well have. Yeah, I think that is correct. I would have done. As I say, sometimes it would be verbal, and another time it may just be a text update.
And also in your statement, you say when you received the call, you were at one of your designated standby points in Fountain Way Campus, Wilton Road, Salisbury. Was that about 7 miles away from Muggleton Road?
Yeah, I have to take the word for it. Yeah, but.
And you say you responded within about 30 seconds of the call.
I believe when the nature of a Category 1 call does come in, yeah, we're pretty much up straight away and out the door as quickly as possible. That's the whole purpose of being a rapid response vehicle.
And I think there was a slight delay in finding the property you indicate in your witness statement because of a problem with the sat-nav, and you asked somebody who was outside if they knew where number 9 was. Do you remember that?
Yeah, I mean, it is a problem because when a new build does occur, we don't get the updates. Our mapping system isn't updated, and in incidents in the past, I found I couldn't find properties because it wasn't mapping. So I've known it take 6 months before we actually get the updates on the
Is that better now? You said in the past.
I think it probably is similar today. Quite often now we get additional information like what 3 words we use, and we use Google Maps as well as the SWAS system, and one may be more ahead than the other. But when you're working solo, you cannot do that because you're driving, so it can be problematic.
Well, we know from the log you are, at least in that area, 199 metres away by 10:23, and it looks like that's the time that you also got to the scene. I want to ask you a few questions about when you first arrived. You described it in your statement. You've indicated new build property appeared to be a 1-storey flat. And you said the door was open on my attendance and I could see the door was open. Is that right?
That's correct, yeah.
Could you describe what happened when you arrived at the front door? And you deal with this at page 6 of your witness statement, because I appreciate it was a long time ago.
Can I just refer to my statement?
Of course you can, at page 6, and it's the second paragraph, the larger paragraph at the top of the page.
So as I've indicated here, I collected my equipment as I arrived at the door, and then, as I say, the door was open. I shouted hello. I heard a male voice say up here. I walked up the stairs. I turned to the right. I state here, I didn't smell anything in the air. And at the top of the stairs, I turned right. I stood in the hallway looking at the bathroom, and I saw a female patient who was laying supine on the floor. That means she's on her back within the bathroom. Her head was towards the door, the bathroom door, that would have been. There was a male partner who was in the hallway, directly outside the door. He had what I believed to be a mobile phone in his hand. And then I said to him, "What's happened?" And he replied, "She collapsed." That was the end of the verbal conversation at that point. I looked down at the female patient. I noticed she was cyanosed. That means her skin is very blue, which would indicate a lack of or no blood supply.
And what was your assessment of her condition at that point?
When I looked at that point, I thought this probably. I noticed she wasn't breathing, and as I say further in my statement, I would have bent down or kneeled down beside her, and I would have felt for a pulse. But my initial assessment was that she was in cardiopulmonary arrest.
And you said you knelt down and felt for a pulse. Was that in her neck?
That's correct. There would have been what we call carotid pulse.
And was that present or absent?
It was absent.
And what did you do next?
I then commenced what we will call basic life support. Even though I had advanced skills, I couldn't give those advanced skills because I had to focus on just chest compressions. And the importance is just to continually press down on somebody's chest, on their sternum, on their heart, approximately 100 times a minute to restart the circulation. That is important. So that's initially what I started to do.
And what else did you do at the same time?
Say again, sorry?
What else did you do? Do you remember making a request to speak
Yeah, I would have, and at that point I would have called for backup or updated my control and said words to the effect of, yes, this is a confirmed cardiac arrest, I need backup, which I think they would have autonomically sent anyway. And other resources would have been also advised, like aerial support, advanced life support.
You say in your statement the operator advised you that a crew would be with you shortly.
Yeah.
And while you were giving basic life support, what conversation did you have with the male partner, who we now know to be Charlie Rowley?
Again, I'll just refer back to my statement.
Yes, of course, page 6. And it's the big paragraph, 3 paragraphs up from the bottom.
So while doing the compressions, I said to the male partner, "Are you the partner?" And he replied, "Yes." I said, "What happened?" He replied, "She was complaining of a headache and she was going to have a bath. I heard a noise that sounded like she was gurgling. I went in and found her collapsed in the bathroom. She was foaming at the mouth. I asked the male partner, when did she collapse? And he replied, 10 to 15 minutes ago. He was quite flustered and he seemed a bit jittery, quite muddled in himself. He didn't really give me much of a clear history as to what the events were or what the reason was for the cause of the collapse."
What was your assessment of what he told you and in terms of the description of Dawn Sturgess?
Sorry, say again?
So when you said he told you she was complaining of a headache, was going to have a bath, and he'd heard gurgling and found her collapsed in the bathroom and foaming at the mouth. So that information, what did that tell you, if anything, about her condition or information?
My initial thoughts, yeah, I mean, you go in with an open mind because it could be anything. You don't know what you're going into. So as the information comes in, you make your assessment. And at that point, I considered that she had a headache. It was acute by the sounds of it. That means it was sudden. She collapsed and lost consciousness. And I believe she had been foaming at the mouth. So my initial thoughts were this was a cerebral incident in terms of a brain injury or something. So I thought maybe she'd had a stroke or something like that, which would maybe cause her to lose consciousness, and that cerebral irritation probably would have caused a seizure. So that was my initial thoughts, that I thought that this was a cerebral incident causing a cardiopulmonary arrest.
Did you also ask Charlie Rowley, we now know him to be the male partner, what her medical history was?
I did, but he couldn't tell me.
Just going back to what you said about Charlie Rowley being a bit flustered and juddery and a bit muddled, did it appear to you that he was unwell in any way at that point?
Well, never ever met Charlie before. I wouldn't know what his normal demeanour was. But no, I think he was, to me, I looked at it from the perspective that this was his loved one or his partner who collapsed, and I assumed that he was very distressed because of that, and having seen this many a times, I thought perhaps this is why he can't give me information, because I have been to calls before where patients can't tell me anything because of their mental state at that particular time. So that's why I considered that. I didn't think he was unwell. I just think he was very muddled because of what was going on.
Right. And you did it occur to you he might be under the influence of something or not?
Not at that point, no.
I think there came a point when you broke away from doing chest compressions. Is that right?
Yes.
What was the next step of the treatment that you applied?
Well, I carried on with the, if I could just refer to my statement.
Yes, of course,
so
and it's page 7 we're on now at the top.
So I broke away from the chest compressions, as I said, and turned on what we commonly call the shock box, which basically is a very portable defibrillator. Everybody used to just call it a shock box. I exposed her chest. I remember that she had, I think, quite a very light fitting top on. So I exposed her chest by, I believe I must have cut the dress off. And then I attached the paddles to her chest, or the pads, the adhesive gel pads to her chest. And then I followed the prompts on the machine. That gave me a verbal indication of no shock indicated. That this would only occur if there was not a shockable rhythm. And in that case, there was no shockable rhythm, which would generally mean that there was cardiac standstill, or what we call asystole. So it was just a flat line at that point. I carried on with chest compressions, and at some point, a little bit later, that's when my colleagues arrived.
Can I just ask you, you said you cut the top dress off. What was she wearing? Do you remember?
I think it was just a dress. I don't think she had a bra on. I think it was just a dress we removed, yeah.
Do you remember trousers underneath or not?
She did have some trousers on, yes.
So there came a point when your colleagues arrived. Was that ambulance colleagues in the first instance?
Yes.
And we won't go back to the log, but we're going to hear some evidence from one of your colleagues. But at 10:33, I think 10 minutes later, they arrived. Was that Keith Coomer and Glenn Davis? Do you remember? Did you?
Say again, sorry?
Was it Keith Coomer and Glenn Davis?
Yes, it was. Keith and Glenn, yeah.
And you knew both of them, did you?
Yeah, I did.
And I think they're lead paramedics. Is that correct? Or they were at the time lead paramedics.
Glenn was the lead paramedic.
And does that mean any advanced clinical skills?
No.
Is it a management role?
No, exactly the same. It was purely for administrative type of duties and things, and maybe they do something like advise new starters and things like that, but it was really administrative, but clinically we were both the same level.
Thank you. And what did you tell them by way of handover? And do refer to your statement if you need to. No, I think we're still on page 7 here. It's about paragraph 3.
I gave Keith and Glenn a handover of essentially what had been disclosed to me by the male partner, Charlie, and the present clinical symptoms the female was presenting with. And that is her being in cardiopulmonary arrest and asystole, meaning a flat line. So that's what I had told them. At that point, I didn't know the cause of what the cardiac arrest was.
And did Keith Coomer take over the chest compressions?
Yes, he did.
And what did you do then?
This is when I started doing some airway maintenance. So this would have involved me tilting Dawn's head back and lifting her jaw forward. So to try and obtain a patent airway. By patent we mean try and clear it by stopping any obstructions from the tongue. And then we have a tube, what we call an eye gel, and that's lubricated and then put into Dawn's mouth, and it lifts the tongue and enables a patent airway, so then we can then ventilate her.
So was she then connected to oxygen?
Yes, it would be. Well, it would be, we would have attached a bag up to that, an oxygen bag, or not an oxygen bag, but a silicone bag, but we would squeeze. Initially it would be atmospheric air, but we would attach an oxygen cylinder, which has got a reservoir bag on the back, which would then push 100% oxygen into Dawn.
And did you help Keith Coomer complete standard chest compressions? If you can't recall, it's paragraph, it's on page 7 still, halfway down.
Yeah, Keith and I were completing standard chest compressions. So what that means is that a ratio of a 15:2. So Keith would do 15 compressions, and on the 15th compression, I would do 2 inflations, and then Keith would carry on with 15. So that is a national guideline standard of the ratio that you should adopt when doing cardiopulmonary resuscitation.
And I think Keith Coomer inserted a cannula into Dawn Sturgess' hand, is that correct? Hand arm, it says in the statement.
Sorry, what was that you said?
Did Keith insert a cannula into her hand
Yes, that's
arm?
right, yeah. Keith put a cannula into Dawn's hand.
Did you notice if her hand was sweaty at all, or if you don't remember, do say?
I don't recall. I mean, it was a very hot day. Environmentally, it was a very hot day, and we were hot. So no, I didn't notice.
And what was she given in terms of treatment then? And again, do refer to the statement if you need to.
We would then give adrenaline, 1 in 100,000, 1 milligrams of adrenaline per every 10,000 mils of saline. So that is basically what we would give first of all to try and reverse the effects of that cardiac arrest.
And that's part of normal advanced life support, is that correct?
Yeah, that would be the initial drug of choice, first of all, to try and restart a heart. And I think I've also noted here that a saline drip of sodium chloride was also administered. That would be purely there just to keep a patent intravenous flow, so we can keep referring back to that intravenous access for more drug therapy.
Did there come a stage when the shock box, the defibrillator, indicated that the patient was shockable?
Again, I'll just refer to my statement here.
Yes, do.
At this point, I think we had, looking at my note, my shock box indicated me via verbal command that the battery was low. And Glenn obtained an additional shock box, which was then connected to the pads which were already on Dawn. So it's just a matter of swapping them over. I mean, periodically the batteries do deplete over a period of time.
Does it tell you immediately when you need the batteries going low? You said a verbal command.
Yes, there is a verbal command on there. Because it was an old system, an old type of defibrillator, it wasn't always a completely accurate gauge. You would have an LCD display that may say that it was completely full, and then it may just deplete very quickly. These devices weren't left on permanent charge at all. They just had batteries in them, and periodically they would change, I believe, when the vehicle went for servicing and that. But the vehicle, it would have been checked at the start of shift when we just turned the shock box on, and it would indicate that the battery was full or half, but within a usable level. But as I say, they weren't completely very accurate, the older devices.
So you say you changed the shock box to a different one that Glenn Davis got hold of, and then was there a verbal command that the patient was shockable?
Yes, it was. I believe what we had to do to make a heart shockable, it has to fibrillate before we can defibrillate it. And the only way to fibrillate the heart is to oxygenate it. So that's why we were doing the aggressive chest compressions to get the blood flow going through the heart. And that's what we've done, along with the adrenaline as well. That would be working to get that flowing through Dawn's blood system, because we have to make sure that by doing those compressions that blood does flow through. And at that point, she was shockable, and the shock was delivered as per the instructions on the...
What was the result of that?
We got what we call ROSC, or return of spontaneous circulation. Again, you can have an active heart rate on the machine, but sometimes there's an electrical mechanical dissociation between the two, so you can have an electrical activity, but there won't actually be any physical movement. So I have to make sure that we did actually have a pulse, and I felt again for a carotid pulse, and I could actually see a pulse as well. I could see it pulsating in Dawn's neck. So I was happy that we had got return of spontaneous circulation.
And you say the monitor attached to the female patient also confirmed sinus rhythm. What does that mean?
Sinus rhythm indicates that the pacemaker site is the sinus pacemaker, which is on the top of the heart. So that would indicate that the rhythm there is coming from the top of the heart and working its way down through the middle of the heart to the base of the heart. So it's what we call NSR, or normal sinus rhythm.
And I think you then tried to obtain some more details from the male partner, Charlie Rowley. Is that correct?
Yeah, at that point, we was happy that we had stabilised Dawn to a level that we could then try and engage with Charlie a little bit more to find out what the lead-up of the events were and why Dawn had collapsed, and trying to obtain as much history as we could.
Could you just, by reference to the bottom of page 7, the last paragraph, and going on to page 8, tell us what it was you asked and found out from Charlie Rowley?
Yeah, so I broke away and left Glenn Davis and Keith, who continued ALS. I then spoke to the male partner. He was standing in the hall at the lounge, in the kitchen area, and I said, can you tell me what her name is? Or her date of birth, or any information as to why she's like this? He did reply, her name was Dawn Sturgess, and it's a name that I hadn't heard before, and I was just trying to get some clarity on how it was spelled. And Charlie replied, no, I'm dyslexic, I can't do numbers. I looked on the windowsill and saw a letter, and it had a name on it. I said to Charlie, is it Dawn Sturgess? Is that her? Referring to the name on the letter. And he replied, yes. And I said, does Dawn have any medical condition? And he replied, not as far as I'm aware. He said she has some tablets. He pointed to some tablets on the windowsill. I can't remember what those tablets were. The conversation lasted about 15 seconds.
Did you look at what the tablets were at the time?
I can't remember. They may have been completely irrelevant.
Did you return to assist the ambulance crew at that point?
Yeah, I carried on with the crew, and I believe that we lost, Dawn's pulse stopped again. Again, we continued with CPR. I checked the machine, more adrenaline was given as per our guidelines, and again we got return of spontaneous circulation. And that's, yeah, we've got return of spontaneous circulation back again.
And then you deal with, in your statement, what we've already spoken about. You've already explained the battery pack. Oh, actually, no, sorry. This was the, you said you'd previously replaced your shock box with Glenn Davis's because of the battery pack.
Yeah,
sorry, go
on. Glenn Davis, he said his EPCR, electronic patient care record, and what we call the brick. In those days, we had a electronic patient care. Well, it was different on the ambulances as to the cars. If you're on an ambulance, your electronic patient care record is, as it says, an electronic patient care record, but it also doubles as a patient monitoring device for monitoring their vital signs, which wasn't a great situation because it was very difficult to flick between the two sometimes. And we had a device, what we used to be called the brick, because it would look like a square house brick. And that connected to the electronic patient care record via a cable. And on the side of this brick, we had connectors, one which would be for blood pressure, one would be for saturations, oxygen saturations, and we also had, we could monitor patients' carbon dioxide levels on there as well. So that's what we're related to, referring to there.
So, sorry, let's just to be clear about this point. So now, what I think you say in your statement is that Glenn Davis's electronic patient care record and brick, the communication box between the medical monitoring devices and the electronic patient care record was faulty. So you had to go and get, so you couldn't monitor the patient's CO2 levels, and so you had to go and get another device. Is that right?
Yeah.
So is that 2 devices that you just had to replace? First of all, the defib, and then
because there was only one ambulance there, there was nowhere else to replace that device with. So effectively, he could do no monitoring through his electronic patient care record because that brick wasn't working for whatever.
But it was a monitoring device rather than a device delivering treatment.
Yes, it was a monitoring device. So what I'd done at that point, if I just refer to my statement.
Yes, it's about 4 paragraphs down on page 8.
Yeah, I returned back to my car and took what we call a Life Pack 12, which is, again, a defibrillator, a cardiac defibrillator, and it has the capabilities to do all the necessary patient monitoring devices on it. So because Glenn's connection had failed, I went down and grabbed mine quite quickly, so then we continued to monitor.
And what did that tell you in relation to the ECG monitor?
It would tell me, well, I could monitor the blood pressure, I could monitor the CO2 levels.
But in terms of what you actually saw, I think halfway down your statement you say there was nothing remarkable on the readings on the ECG, is that right?
Yeah, I think that's what I put. Let me just refer to that.
Yes, halfway down page 8.
Yeah, I would have done an ECG.
And what about Dawn Sturgess's condition you addressed there?
Sorry, say again?
You addressed Dawn Sturgess's condition at that point. When you say halfway down, I got back to airway management.
Yeah, so we got back to airway management, and I was bagging Dawn. That means that I was squeezing the bag, the oxygen in. I mean, this would have been continuous anyway, but we generally do take turns so we don't get fatigue and doing one particular treatment continuously. She was nice and pink in colour, and as I stated here, her chest was rising well. I noticed her right hand, my right hand glove had split at the top of the thumb, and I had some mucus which had come from Dawn's mouth onto my hand glove. This would have occurred while I was doing some airway management.
Did you change your glove?
I believe I did.
And did you experience any symptoms of being unwell in the days after treating Dawn Sturgess?
Myself?
Yes.
Not that I can remember.
Thank you. And then I think there next came a point, and we'll hear subsequent evidence, it was about 11:05, I think, that critical care paramedics arrived. Is that correct?
That's correct, yeah. The critical care crew arrived. Again, this consisted of another key, which I referred to as key 2 in my statement. another unknown paramedic who I hadn't met before, and a female, which I later learned was I believe, a critical care nurse who was there on an observer capacity that particular day.
And did they take over the ROSC care, the return of spontaneous circulation?
Initially, I would have given them a handover, a clinical handover, and I would have told them what had occurred or what we thought had occurred, and what we had done to, what treatment we had done for Dawn in terms of, we've got an IV and she's had several shocks, what drugs she'd had, what airway maintenance she had, and probably what are the baseline observations in terms of ECG, whether she had blood pressure, oxygen levels, and what other observations we would have noted, which would have been important for them to know.
Yeah. When were you aware of the critical care paramedics giving naloxone?
I think, I believe they may, yeah, possibly. I cannot remember, but I do know that if part of our protocol, when we get a patient who's in cardiopulmonary arrest, we always have to consider whether there is an opiate, possibly. If we don't know, if we didn't know whether there was an opiate involved or not, we could give that drug, because if there was an opiate involved, it would stop the effects of that opiate. But if there wasn't an opiate involved, it would have no detrimental effects on the patient. But I never thought that there was any. My initial thoughts were that I always thought this was a cerebral episode or a neurological episode. And I thought possibly it may have been a seizure caused by a brain injury or something.
So once the critical care paramedics arrived, I think you had an opportunity to speak to Charlie Rowley again, and you deal with this at page 9. Halfway down page 9. What did you ask him at that stage?
On page 9.
The paragraph starting, I changed my gloves.
Yeah, I changed my gloves at this point. There was a lot of involvement in treating Dawn. I said to the male partner, are there any prescriptions or hospital details? And Charlie replied, I don't know. I said, do you mind if I have a look around for something? Because part of our job is trying to investigate, to find out what has occurred. Again, Charlie didn't reply, and he did look a little bit confused at that time, which again, as I think, possibly may have been down to how he was feeling. I looked around and I could only see a letter from Wiltshire Council, but they only gave me her name and nothing else. Initially, I was looking around to see whether there was a hospital letter or something, or even a prescription to see whether there was any particular medication Dawn was taking.
But you didn't find anything?
I didn't find anything.
Did you see any drug paraphernalia?
No.
Were you aware of Charlie Rowley saying anything to Keith Coomer about Dawn not taking drugs?
No, I never knew. I never, no.
Did Charlie Rowley tell you at any point that Dawn had not taken any drugs?
No. And I don't think I ever asked that question either.
And just to cover the treatment, once the critical care paramedics had arrived, you said at the end of page 8 that we connected an ETCO2 probe to check her oxygen levels, checked her blood glucose, nothing remarkable. And I think you noticed a suction unit being brought in, is that right?
I believe so, yeah.
And what's that used for?
The suction would be to maintain a patent airway, because 90% I would say, in my experience, 90% of patients who are in cardiopulmonary arrest have some fluid coming out of their mouth or their nose.
So secretions are common in cardiac arrest then?
Yeah.
Very common if it's 90%?
Yeah, it's very common having fluid loss. Yeah,
Do you remember noticing excess secretions in Dawn's case?
I do remember fluid coming out of Dawn's mouth, yes.
And I think you helped take her on a scoop stretcher to the ambulance. Is that right?
Yeah,
and I think you noticed that she lost control of her bowels at that point.
That's correct, yeah.
I think you suggest she was wearing trousers at that point.
Yes.
And once she was taken into the ambulance, you say I had no further contact with her at that point. So is it right you weren't involved in her care in the ambulance?
Yeah, I handed over to the other team and the critical care team and took over from there, yeah.
When you helped to transfer her into the ambulance, were you aware that she was bradycardic and hypertensive?
Was I aware she was?
Bradycardic and hypertensive, if I pronounce that correctly.
No, I don't think so.
Did you notice a white frothy liquid rising in the eye gel?
Possibly, but it wouldn't have been abnormal to have a white frothy type of fluid in an eye gel because, again, probably 90% of the cardiac arrests that we go to would have fluid in an airway. That's the whole idea of us having a suction unit to remove that.
So you've explained that when you first came, you thought it might be a stroke and you thought it was a brain, a seizure of some sort. And by the time you put her in the ambulance, what were your thoughts as to what might have caused the arrest?
Again, I was still thinking on the basis of, we didn't know, none of us knew, and I think I did say that it was an unknown cause. But there was nothing which was clearly indicating what the cause of it was because Charlie couldn't give us much information at all. Couldn't find any medical notes to say that Dawn had a pre-existing medical condition. And my personal thoughts were, again, I always thought it was a neurological episode, and I thought, as I say, she possibly could have had a stroke, which could have precipitated a seizure, and thus a collapse.
Did you consider any of her symptoms to be particularly unusual in the context of cardiac arrest?
Did I say again?
Any of her symptoms to be particularly unusual, given that cardiac arrest, obviously unusual, but in the context of cardiac arrest, anything in her symptoms that you thought was particularly unusual in your experience?
No, there was nothing which was really red flagging to me at all.
And it may be obvious from what you said, but presumably then you didn't consider that organophosphate poisoning was a possible cause at all?
Anything's a possible cause. When we get on scene, you have to find as much information as you can and think, but there was nothing at that point saying to me that this was a poisoning.
Thank you very much. Those are all my questions. There'll be some more questions for you.
Have you anything, Mr. Mansell?
Yeah. Good afternoon. I represent the family of Dawn Sturgess. Just a couple of questions. First of all, before you went on this particular day, were you ever alerted to the fact that Novichok might still be present in the Salisbury area?
Not by my ambulance control, but it was always at the back of my mind being a healthcare professional, and because of events prior to meeting attending Dawn, it was anything would be possible. So I would have been, as I say, maybe a little bit more guarded. I think I would consider those things.
Right. From what you're saying then, there hadn't been any official training or information about Novichok before you went, or the presence of it?
Only the updates that we had received after the Salisbury incident, just to the update that we got to remind
Yes.
staff of the procedures of hazardous chemicals.
One final question on that, and that is, was the issue about a possible crossover or misdiagnosis of a nerve agent reaction with an overdose of drug, was that something that you had been discussing at all?
No, I don't think so.
No. And one final question altogether, and that is, you came to the conclusion, and you maintained that throughout, that you thought it was a neurological episode.
That's correct.
Now, was that an instinctive reaction, or was there a feature of this one that you thought led to that conclusion?
I think it was a feature because the information I got from Charlie was that it was acute, it was sudden. She was complaining of a headache, again, which was acute, and that she had been foaming at the mouth. So those are factors which can be indicative of a neurological episode.
All right. Yes, thank you very much.
Thank you, Mr. Mansfield.
Sir, I don't know if this would be time for an afternoon break.
Yes, it would. Mr. Marriott, we're grateful. Thank you very much indeed. There's no need to stay unless you want to. Of course, you're free to do so. 3:15, please.
All right.
Yes, Ms Fox.
Sir, the next witness to be called is Keith Coomer.
I'd just like to repeat after me. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the
and
truth.
nothing but the truth.
Thank you, Mr Coomer. Yes, by all means, sit down if that's comfortable.
Good afternoon, Mr. Coomer. My name is Emily Pottle, and I ask questions on behalf of the inquiry. Thank you for attending to give your evidence this afternoon. Could you give your full name, please?
Yeah, my name's Keith Coomer.
Mr. Coomer, you've made 2 witness statements in this case, I believe. The first is dated the 6th of July of 2018, and the second is dated the 13th of July of 2018. And the references for those statements are INQ 4550 and 4560. If we can bring up, yes, 4550 and 4560 on the screen. You should see that, Mr. Coomer, on the screen in front of you.
Yes.
Okay. And if we turn, if we begin with 4550, if we just turn to the last page. Yes, so we can see this is the main statement, if I can put it that way. It's 4 pages long. Do you recognize that statement, Mr. Coomer?
Yes, I do.
And have you had a chance to review the statement
Yes.
before giving your evidence?
Yeah.
And is it true to the best of your knowledge and belief?
Yes, it is true.
Is there one correction you'd like to make?
No, I'd just like to state that I was in sort of a state of shock at the time of the statement,
I see.
just through going to a cardiac arrest and a few days later being told it's a major incident of Novichok.
I see. Well, we'll go through the statement in detail in a moment.
Yeah.
And you can make amendments that you feel are necessary. But just before we do that, the second statement is, if we can just pull that up, 4560. It's just a single page, and it just corrects a typo. Confirms that the date is the 30th of July, 2018. And sir, if you are content, could both of those statements be adduced into evidence?
Yes, it's June 4 July, isn't it? Yes, of course, both statements.
Yes, of course. Okay. Now, Mr. Coomer, before I ask you about the poisoning of Don Sturgess and your role, I'd just like to ask you a bit about your qualifications, if I could. So in 2018, when you responded to the call at Muggleton Road, you were an advanced technician working for Southwest Ambulance Service, is that right?
That's correct, yeah.
Can you just tell us in a few words what the role of an advanced technician is?
I've just got additional skills than a normal technician, sort of cannulation.
Okay, and in relation to a paramedic, what would you say?
I'm not registered.
Pardon me?
I'm not registered.
Not registered, okay. And so would your level of training be the same as a paramedic or a bit lower or?
A little bit lower.
A bit lower, okay. And so would you normally, we know that on the date in question, you were crewed with Glenn Davies, who was a paramedic.
Yeah.
Would you normally be crewed with a paramedic? If you
Not normally. Well, it changes. Whoever. I've been doing shifts along with ECAs. They even put technicians on the car as well.
Okay, so not always with a paramedic?
No.
Okay. And how long have you been an advanced technician?
I've been with the ambulance service about 2005.
Okay, so nearly
So
20
coming up
years.
20 years.
Yeah, okay. Okay. If I can ask you then, before we move on to the events in question, I want to ask you a bit about your training and guidance that was given to you on organophosphate poisoning. Mm-hmm. Good, okay. We heard this morning from Wayne Darch that a clinical notice regarding duodote autoinjectors was emailed to all paramedics, he says, prior to the Skripal poisoning, and all clinical staff were asked to familiarize themselves with it. And the clinical notice itself asks clinicians to look at the medicine's protocol for a duodote autoinjectors. And if we can just pull up that medicine's protocol now. Thank you very much. That's for the transcript, it's INQ reference 623. And we've looked at this document twice already today, but Mr. Coomer, could I ask you, do you recognize that document?
Yes, I do.
Okay. Did you see it prior to June of 2018?
Yes.
You did, okay. I'm just going to take you through it in a bit more detail now. So if we look at page 1, it sets out the clinical diagnosis of nerve agent poisoning and sets out a number of features, including bronchuria, which is the production of excess watery sputum, bronchospasm, which is difficulties with breathing, is that right?
Yeah.
And severe bradycardia, so that's a slow heart rate.
Slow heart rate.
Yeah. Okay, and if we can, then it says other signs may include, if we can move on then to page 2. So the other signs are excess secretions, for example, tears, respiratory depression, and altered level of consciousness and convulsions. And then the protocol says that toxic doses can cause CNS, that's central nervous system, is that right? Yeah. CNS stimulation, which can cause, for example, restlessness and confusion. But that can give way to depression, so central nervous system depression, which would cause coma, circulatory and respiratory failure and death. And so if we're considering Dawn Sturgess's case, she had, we now know, circulatory and respiratory failure caused by that poisoning. If I can then ask to move to page 5 of the protocol. So this is the final page of the protocol, which I think we saw just a moment ago with your colleague, Mr. Marriott. And if we can just focus in on the bottom of that page, the grid. Yes, sorry, that's a little too focused. We should zoom out just a little, thank you. I want both grids, I should have said. Perfect. Here we have quite a clear exposition of the signs and symptoms of the poisoning. So for breathing, chest tightness, wheezing, respiratory arrest, bradycardia, pinpoint pupils, meiosis, seizures or unconsciousness, sweating, fasciculations. Can you help us with what fasciculations are?
I'm not sure.
Not sure, okay. We'll hear, sir, from an expert in pre-hospital care in due course. And then also, finally, other nausea, vomiting, fecal and urinary incontinence are the other signs and symptoms. So I know that I'm asking you about events that occurred quite a long time ago, but you recognize the document. Do you think before you attended to Dawn Sturgess at 9 Muggleton Road, you were familiar with the signs and symptoms of nerve agent and organophosphate poisoning?
Yeah, because I read the notice and signed for it.
Oh, you did? Okay.
Yeah.
I see. I see. Now, I want to ask you about information received after the Skripal's poisoning, but before the poisoning of Don Sturgess. So, you know, you weren't involved in these events, but of course in March, Sergei and Yulia Skripal had been poisoned in Salisbury. And we heard this morning from Mr. Darch that some guidance which had been intended for emergency departments had been emailed through, he says, to all staff. And I just want to show that to you and ask if you remember seeing it. So that is, the reference is INQ 659. Perfect. Thank you very much. And we needn't take a long time with this, but it is a document which sets out a reminder for clinicians for recognizing the signs of organophosphate poisoning. And it begins on the first page with recognizing the release of the chemical and the step 1, 2, 3 plus triggers. And just to spend a little time on that, the step 1, 2, 3 plus triggers, those numbers refer, don't they, to the casualties?
Number of patients, yeah.
Number of patients, exactly.
Yeah.
So in your case, when you were responding to Don Sturgess, you only had one patient.
Yeah, step 1.
Yes, exactly. Okay. And if you'd had 3 patients at that address, then this sort of protocol, the step 1, 2, 3 protocol, would have required you to seek specialist responders. Yes. Is that right?
Yeah.
Okay. But you weren't there, obviously, when you were attending to Dawn on her own. And then the other sort of indicators would be dead people and animals, unexplained signs of irritation on the skin and the eyes and the airway, the presence of hazardous materials and unexplained vapor, mist and clouds. And then the clinical symptoms, they begin on page 1. And if I can take us now just to page 3, which just sets out the acute effective exposure. And we needn't take a long time because they're the same as the ones that we saw in the duodote protocol. Yes, there we go. So increased salivation, chest tightness, rhinorrhea. Rhinorrhea, is that secretions from the nose?
Yes.
Okay. And bronchorrhea, bronchospasm, meiosis, so the pupils that are constricted. We also see as the acute effects, you can have hypoxic, this is the very last bullet point, late complications may result from aspiration or a hypoxic brain injury from early loss of consciousness and respiratory failure, which we know is what happened in the case of Miss Sturgess. Okay, so do you recall getting this by email?
I don't recall it, no.
Okay.
Don't recall having it or don't recall how you got it?
If we, as I say, it was 6 years ago, a lot has sort of happened in that time, but it would have been on the table, I'd have read it and signed for it.
Okay.
Okay. But in any event, you've confirmed that, you know, with the duodote protocol, you remember that you knew the signs and symptoms at the time.
Yeah, the duodote, that's on the ambulance along with the card as well.
With the card, okay.
With the card.
Okay. So you could refer to that at any time.
Yeah.
When you're out on a call. Great. Okay, then I'll move now to the events on the 30th of June. And please refer to your statement if you need to, because it was some time ago. On that date, you were on duty as part of a double-crewed ambulance.
Yeah.
Partnered with Glenn Davies. He was driving.
Yeah.
Okay. And your ambulance was call sign 312, is that right?
That's correct.
Okay. I'm going to take you now, not to the call log, because it can be a little difficult to make sense of, for me anyway. But I'm going to take you instead to the distillation of the call log by the expert, the pre-hospital expert, Mr. Faulkner, and that is INQ reference 5942.
5942.
Yes, 5942, page 37. It should come up on your screen in just a moment.
Yeah.
Yes.
You were call sign 312, so we can see here on at 1016 it says resource call 312 allocated to the incident.
Yeah.
And actually at the very top we can see the call was received at 1014. So you're allocated 2 minutes later.
No, that's, oh, sorry, 312, yes.
Yeah. Yes, so 303 is Mr. Marriott, who
That's
we
right.
just heard from, yes. So actually at the same time, you are allocated to the incident. And we can also see at the top of the page that it was a category 1 call. That's the highest level of priority. Is that right?
That's correct.
That's correct. And at that time, the complaint is given as fitting. And then we can move down the page at 1023. It says call recorded as cardiac arrest. So it's still a category 1. Do you remember on the date in question whether you were receiving that information as it came through?
Initially come through as a fit-in, but as en route to Amesbury, it went down to cardiac arrest.
Okay. And did you, Mr. Marriott told us that he had a mobile data terminal in his RRV. Do you have a similar setup in the double crewed ambulance?
Yeah, we have radio plus the MDT.
Okay, and then as the information changes, does that new information come through on the MDT?
I think that came through via radio,
Okay,
that it was a confirmed cardiac arrest.
and that's dispatchers from the control room
Yeah.
keeping you informed of what's happening?
Yeah.
Is that right? Okay, I see. If we continue down the page, we can see at, it says 1029, notes added stating cardiac arrest confirmed by RRV. That would be Mr. Marriott.
Yes.
Yeah, so he confirmed it. And then it says your call sign arrives 4 minutes later at the scene. Does that accord with what you remember? You arrived after Mr. Marriott was there.
Oh, he was first on scene,
Yeah.
yes.
Okay. And then before we go into a bit more detail, can I ask that the call log also sets out when the first set of observations were recorded, when adrenaline was given, and when other medical interventions happened. How does that information end up on the call log? Are you in control with are you in contact
don't.
with the control room on the scene, or?
No, that doesn't make no sense to me.
Okay. Well, if you can, if you can't
We
help us
just
with
arrived
that,
on
then
at 10:33, so I can't see any drugs being given at that time.
no. Okay. But don't worry. If you can't help us with the call log, you must simply tell us what you
Yeah.
yourself saw and what you know about. Okay. So then, you arrived at the scene. Mark was already there. Can you just paint a picture for us? When you arrived at the address, we know you went up the stairs, you went into the bathroom. What did you see at that stage?
Went up the stairs, turned right. Mark was at the head on his knees doing CPR. He gave me a quick handover. I squeezed through the doorway, and I went, moved her left arm to give me some room. I knelt down on her left-hand side and commenced with CPR to
Okay.
give Mark a rest as per protocol.
If I can just pause you there. When you say he gave you a quick handover, do you remember what he told you?
Collapsed, query cause, and in cardiac arrest.
Okay. And so you knelt next to her, you moved her arm so there was space for you.
Yeah.
And you started to help him. What were your actions to help him?
To get the heart going.
Okay.
cardiac arrest.
So did you start bagging her, or were you doing
No, I was on the
compressions or-
chest.
You were on the
Free
chest.
him up to get the airway.
I see. And Mr. Marriott told us that when he was on his own, he could only do basic life support.
That's correct.
But then when you arrived, you and Glenn, that it was possible to do advanced life support.
Yeah.
Can you just help us with what the difference is between basic and advanced?
Basic is applying pressure to the heart, onto the chest. You're acting as the heart, keeping the heart going.
Okay.
And also, you've got a bag where you're giving oxygen as well. Well, oxygen as well, yes. And with advance, that's giving drugs.
I see. Okay. You cannulated Dawn
That's
Sturgess,
correct.
that's right, isn't it? And was that to her hand?
No, up into the ACF, up into her arm.
I see. Sort of her elbow area.
Yeah,
would
that's
that be?
correct.
Oh, okay. Did you notice when you were doing that whether her skin was sweaty at all?
No.
Okay.
No, you didn't notice, or
No, I didn't notice.
there's no reason why you should. I just want to know what the no means, that's all.
Yeah.
Okay.
Okay. Can we pull up inquiry reference 655? Mr. Akuma, I'm going to take you in a moment to this document, which is, I believe it's the electronic patient record.
Yeah.
Is that right? Okay.
Yeah.
If we could, can you help us? How is this document completed?
I didn't do this one, but normally at the top, you just write in explaining what you did, what you've seen on the scene.
Okay.
Then the next one is sort of like a primary survey.
Can we just, sorry, I know I said page 2, but could we begin just at page 1, just to help? Yeah,
Yeah.
so this is what you were talking about, I think, the primary survey.
Yeah, on arrival was with the free text.
But can I just ask, before we get into the details of what's included in the form, because it's called an electronic patient record,
Yeah.
that suggests that it's not done by hand.
Not no more, it's all electronic now.
Yes, exactly. And Mr. Marriott was, in his evidence, telling us about an electronic patient record, which was like a sort of tablet.
Yeah.
Is this something that's completed that you type up when you're on the scene, or is there automatic input
Depending on
from
the condition
machines?
of the patient. If the patient needs all your help, you're concentrating on the patient,
Of course.
and you do the paperwork later.
And so in Dawn's case, when you were assisting Dawn, I think the expert notes that there's some inconsistencies in the record. He hypothesizes it's because you were probably helping Dawn rather than
That's
filling
correct,
it in.
yeah.
Is that what happened?
Yeah.
Okay, I see. So we have the primary survey here, which says that the presenting condition is cardiac. And it says OOH, cardiac arrest. Can you help us with that? What does that mean? Is it out of hospital? Cardiac
Out of hospital, cardiac arrest,
Yeah.
cardiac arrest before ambulance arrival.
Yeah, okay. And then if we turn to page 2, it says, collapsed in a toilet, went into arrest, RRV on the scene, BIs commenced. What's BIs?
I think that's meant to be BL,
Oh, okay,
basic life support.
I see. Ambulance arrived, ASU in attendance. Who's ASU?
That I'm not sure.
Okay. And then extricated on scoop, ALS continued. ALS is advanced life support, is that right?
That's what, yeah. As
Yeah.
I say, I did not write this one, so abbreviations are going to be a bit different.
Of course, and it says actually Fred Thompson completed the EPCR.
Yeah.
And so we're going to hear from him tomorrow morning.
Right.
So I don't think, I'm not going to trouble you too much more, Mr. Coomer, with this document, but just to say that we can see here on examination underneath that box on page 2, they say that the pupils were sluggish, left size 1 millimeter, right size 1 millimeter.
Yeah,
And so that would be meiosis, is that right?
yeah, pinpoint.
Yes, so 1 millimeter is quite small.
Yeah.
Okay. And then there are some indication of the drugs given, that's on page 3. And then the treatment. If I can just ask you then to put that document to one side, we can take it down now. If we can get back then to the medical treatment that you remember giving her. So you cannulated her to give her some drugs. That would be part of the advanced life support. You'd been helping with compressions. You did eventually achieve a resumption of spontaneous circulation.
Yeah.
That's right, isn't it? Okay. Can you help us with, and you might not be able to, but with the time that happened? Because the patient record says that it was about 10:51. Does that sound right to you?
That's about right, yes.
Okay. Okay. I'd like now to ask you to look at document INQ 5294, page 3. This is a debrief that was conducted by SWAFT of the incident. The debrief took place shortly after. And you attended this debrief, is that right?
Yes.
Yes, okay. The incident 120-43565, that's the response to Dawn Sturgess at 9 Muggleton Road. We can see that they record your ambulance 312 was second to arrive on the scene. You entered the property wearing gloves, and then there's the equipment that you brought, including the suction unit. And the eye gel unit was placed by Mr. Marriott. Then if we look at the fourth paragraph, is what I'm interested in. It says, once double crewed ambulance 312 were in scene, advanced life support was commenced. The patient was cannulated in the left arm, and medicines were administered via this route. The patient then had a return of spontaneous circulation. However, after a while, the patient had a VF cardiac arrest. After one shock, the patient's rhythm went to, how do I pronounce that word? It says?
Systole.
Asystole. So after one shock, the rhythm went to asystole, but after further advanced life support, there was a further return of spontaneous circulation.
Yeah.
Does that accord with your memory of what happened?
No, I can't quite remember that.
I see.
I remember her having one shock and she went into ROSC,
Yeah.
returned to spontaneous circulation.
Okay.
But we had HEMS arrived, critical care.
I
When
see.
the critical care arrived, I went down to get the ambulance ready for extrication.
I see. So you continued providing care until the critical care team arrived?
That's correct.
Okay. I'd just like to ask you now about the interactions you had with Miss Sturgess's partner, Charlie Rowley. Do you remember speaking to him about Dawn Sturgess's condition?
I think that went all through Mark.
I see.
I didn't see much of Mark, Charlie. If I did, it was only for a fleeting few seconds because I was busy on Dawn.
I see. Do you recall Charlie Rowley confirming that Dawn Sturgess did not take drugs? Do you recall?
I don't recall that, but if I did ask it, it was just a rule of elimination because we were just trying to find out why she collapsed.
Okay. Did you form a view while you were treating her what the cause of her symptoms was?
Again, I was going down the neurological route.
I see. And when you say neurological route, what kind of conditions were you considering?
Sort of, like Mark said, it's sort of seizure type, brain injury.
Okay. Do you recall noting that she had meiosis?
Yeah, pinpoint pupils.
Okay. And that didn't cause you to think that it could be a drugs overdose?
It goes through your mind. Loads of things are going through your mind all at once. And you just got to eliminate things. Hence why we give a naloxone.
Okay. Do you remember the suction machine being used to remove excess secretions in her airway?
I might have been downstairs then getting the ambulance ready.
Okay. So you don't remember that?
No, but suction was used on in the back of the ambulance, but I don't remember it being used up in the bathroom.
Okay. And Mr. Marriott told us that it's very common for there to be excess secretions. Is that your experience?
Yeah, it's boiling down to sort of fight or flight syndrome. Your body's trying to concentrate on providing energy, blood circulation to the important organs of the body.
Okay.
So you vomit, you lose secretions, fecal matter.
So the symptoms that you would have been aware of when you're treating Dawn Sturgess, the excess secretions, the incontinence of fecal matter, and the meiosis, did you consider that those were an unusual constellation of symptoms or no?
No.
Okay. Can you help us as a working paramedic of 20 years experience now, whether those are symptoms that you would expect to find in somebody who is in cardiac arrest or not?
Everybody's different, but I've been to cardiac arrest where there's been huge amounts of vomiting, but with Dawn there was no vomiting.
I see.
Everybody sort of portrays differently.
I see. You mentioned a moment ago that naloxone was given to Dawn. Did you notice whether that had any effect on her?
But I don't know. We were too busy then trying to get her out of the house and into the next level of care.
I see. And just help me with this. The naloxone, was that given by you before the critical care team arrived, or was that given after?
I give it as they arrived because I put it past them. I said, is it all right to give her that? And they said yes.
Okay. I see. And you gave that to her for what reason?
If it was opiate.
I see. And if it wasn't opiates, was your understanding that there would be any negative consequences for her?
It's not going to do anything bad, but it'll help reverse causes if it was.
Okay. And you didn't notice whether there was any impact on her?
No.
Okay. Arrangements were made eventually to move Dawn onto a scoop stretcher so that she could be put into the ambulance. That's right, isn't it?
Yeah.
And what was your role in that part of her care?
HEMS, the critical care, they took over the care for Dawn then.
Okay.
I was just assisting with lifting and assistance in the back of the ambulance.
Okay. So did you help carry her down the stairs? Yeah. Okay. And then when she was put into the ambulance, were you in the back of the ambulance with her? And did you stay with her until she arrived at hospital?
Yeah.
Okay. When she was in the back of the ambulance, she was intubated, is that right? Do you recall?
Vaguely, I can recall. But Fred, he was up at the head end, and I was bandaging where she started sweating and losing the Veco fix for the cannula. So I was bandaging
okay,
cannula
so
in place.
I see. So at that stage, when she was in the back of the ambulance, you noticed that she was sweating, and that's
Yeah.
why she lost the cannula that you'd put in earlier.
She didn't lose the cannula, but you losing the Vecafix.
That's the adhesive, is it?
It's just like a sticky plaster sort of thing.
I see. Okay. And would it be unusual for somebody to be sweating after
No, not
cardiac
really.
arrest? Okay. Mr. Coomer, I can say that the inquiry is going to hear expert evidence from a expert paramedic, Mark Faulkner. And I can say that he has concluded that the care given to Dawn by paramedics on that day was of a reasonable standard, and he doesn't criticize the care provided. But I'd like to ask you that by the time you were in the back of the ambulance and you'd noticed the sweating and the meiosis, the respiratory arrest and the cardiac arrest, did you think at that stage that her symptoms might be caused by organophosphate poisoning?
No.
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 Okay. And what at that stage at the end, what was your thinking as to the cause of her symptoms?
I was still going down a neurological event.
I see. Okay. Thank you very much. I have no further questions for you, but there will be some questions.
Thank you.
Thank you, Ms. Bartle. Are there any... Yes, Mr. Mansfield.
Is that on? Yeah, it is on. Yes, good afternoon. I represent the family of Dawn Sturgess. I just want to ask you about a document that was on the screen a moment ago. I don't ask for it to come up again. So this is the debrief that we've just seen. Can you help on this? That when you get back to the hospital with Dawn, can you recall how long after your arrival back at the hospital that the debrief is carried out and who carries it out?
No, I can't remember that one.
Can you give us an idea of how long after you returned? Is it something that's done fairly soon?
It depends on the trauma.
You mean how serious it is?
Yeah.
All right, well, this is pretty serious. So is the likelihood that those dealing with Dawn would want to know from you, and obviously anyone else, all of you, the crew, as much as you could tell them about the circumstances?
They'll only give us the information as they receive it back from the hospital.
What's the purpose of the debrief, Mr. Kermer, as you understand it?
It's sort of welfare, really. Keep you in the picture to make sure you're okay. And because of the seriousness of this, they just wanted to put everything together.
Right. And is there always a debrief when you get back with a patient?
Not always, no.
And when there is, well, was this one that same, where are we? Morning, I think, or sometime later in the day?
This was not, no, it wasn't the same day.
Not the same day?
No. I think you'll find there's a date on the debrief.
Sorry? That's the debrief date. Yeah, okay. What is the date on that? Is it the 4th? At 6:30. 4th at 6:30, apparently, this one.
4th of July,
Yes,
so a few days later.
yes.
Thank you.
And does, the reason I'm asking you is obviously information you had could have been important for the doctors. Does any doctor come and see you, or consultant come and see you, or registrar come and see you and say, what happened and so on, to get information because they're dealing
Again,
with...
that'd be boiling down to the person who handed over, and I believe it was Fred Thompson who handed over the patient.
Right, so it's part of the handover.
Yeah.
Because we saw on the, again, I'm not asking for that sheet to come back, on that same sheet, the debrief sheet, that's where it also shows that Charlie Rowley had been saying and telling people that, more than just you, 2 other people, that Dawn had not taken drugs. But can you help any more about that?
It's just asked it for a rule of elimination. As Dawn collapsed, it's just a question as to how, why she collapsed.
Yes, I understand. Yes, thank you very much.
Thank you, Mr. Mansfield. Mr. Coomer, thank you very much for your help.
Thank you.
There's no need to stay unless you wish to. Thank you. Where do we go from there, Miss Bottle? Is that the end of the day?
Yes, that is the end of the witness.
Well, we'll have to put up with that as best we can. And tomorrow morning at 10 o'clock, please.